A 68-year-old female presented with worsening headaches. I am showing you axial non-contrast CT and pre- and post-contrast sagittal brain MRI scans. Describe the findings.
Okay, I see it. The non-contrast CT scan demonstrates a poorly defined, mildly hyperdense midline mass extending across the body of the corpus callosum. Notably, there is no significant surrounding vasogenic edema or mass effect on the ventricles, which is typical for callosal lesions owing to tightly packed tracts. On the corresponding MRI scans, there is an incidental cavum septum pellucidum noted. The pre-contrast T1 weighted MR image shows the callosal mass as mildly hypointense. Following intravenous contrast administration, there is avid uniform enhancement of a lobulated lesion that crosses the midline through the body of the corpus callosum.
I am showing you a magnified post-contrast axial T1 weighted MRI. What is the diagnosis and what is the differential for a corpus callosal lesion crossing the midline?
In that case, the diagnosis is a butterfly glioblastoma multiforme, also termed glioblastoma, WHO grade 4. The differential diagnosis for a midline crossing corpus callosal lesion includes a primary CNS lymphoma, a demyelinating plaque from multiple sclerosis, and a tumefactive demyelinating lesion. Glioblastoma and primary CNS lymphoma are the two most common and important entities to distinguish in this region.
Explain how to radiologically differentiate glioblastoma from primary CNS lymphoma and demyelination in the corpus callosum.
Well, glioblastoma typically demonstrates heterogeneous or ring enhancement with central necrotic or cystic changes in about 95% of cases, although callosal lesions can enhance uniformly. Primary CNS lymphoma is typically hypercellular, appearing hyperdense on CT and T2 hypointense on MRI, and enhances uniformly without cavitation or necrosis, except in immunocompromised patients. Demyelinating lesions, such as multiple sclerosis plaques, usually show incomplete ring enhancement and follow a more indolent course with typical eccentric location. Magnetic resonance spectroscopy can also help. Glioblastoma shows elevated choline and lipid or lactate peaks with depressed NAA, while lymphoma shows a high choline to NAA ratio with less necrosis.
Discuss the pathology, routes of spread, and demographics of glioblastoma multiforme.
Glioblastoma is the most common and highly malignant primary brain tumor in adults, with a peak incidence in the 7th and 8th decades. Pathologically, it is characterized by nuclear atypia, mitotic activity, cellular pleomorphism, vascular endothelial proliferation, and palisading necrosis. It spreads by direct extension along white matter tracts, such as the corpus callosum or cerebral peduncles, creating the classic bilateral butterfly distribution. Spread via the cerebrospinal fluid occurs in less than 2% of cases, and hematogenous metastasis is extremely rare.
How would you manage this patient as a radiologist, and what are the primary therapeutic options?
I would recommend an urgent neurosurgical consultation for stereotactic biopsy to confirm the histopathological diagnosis, as surgical resection is rarely possible for butterfly gliomas. A baseline advanced MRI, including diffusion-weighted imaging, perfusion-weighted imaging, and MR spectroscopy, should be obtained. The standard therapy for glioblastoma is maximum safe resection, followed by adjuvant temozolomide chemotherapy and radiotherapy, known as the STUP protocol. For butterfly glioblastoma, treatment is usually limited to palliative radiotherapy and chemotherapy due to the morbidity of callosal resection.